Okay, good morning. I think the scientific sessions have been going fabulous. I know there's a few people who are going to trickle in a little bit later from the thyroidectomy guidelines as they have to come down the escalators. So that'll give me a chance to introduce Dr. Wen Shen, who is our MCW Stuart Wilson historical lecturer today. Dr. Shen is a highly respected endocrine surgeon and a professor of surgery at NYU. Many of us know him, of course, from his decades of educating the next generation of endocrine surgeons at UCSF before he moved to NYU. The side of him that everyone may not know is that he's a history of medicine buff, and he got his master's in the history of health sciences from UCSF. And even since he was a medical student, he had a deep interest in the history of medicine and blending that with endocrine surgery. He's known for his generosity as a teacher and educator. And I've known him since he was a medical student. I'll give a funny story about one of the other medical students at UCSF when I was a resident. The father of that medical student had to have hernia surgery. And of course, he came to Orlo Clark to have the hernia surgery. So when Shen and I met for the first time, while Orlo was operating on this other medical student's dad doing a hernia surgery with local anesthesia and teaching us exactly how to do it. So I'm not sure if we were scarred or not, but it was a great experience. So with that, we're going to welcome Dr. Shen to give us a little talk about Oliver Cope, a very special person.
Excuse me. Good morning, everyone. And thank you for this tremendous honor of giving this year's MCW Stuart D. Wilson Historical Lecture. And special thanks to you, Saray, for your kind invitation and that introduction, and for trusting this guy from San Francisco and New York to tell the story of one of Boston's most celebrated and beloved surgeons, Oliver Cope. I want to start off with a few words of gratitude for Dr. Stuart Wilson, for whom this lecture is named. As many of you know, Dr. Wilson is Professor Emeritus at MCW and a true legend of endocrine surgery, and his impact is spread far and wide within our field. And when we talk about endocrine surgeons being the friendly surgeons, we're talking about people like Stu Wilson. I first met him at the 2005 AAES meeting in Cancun when I was a research resident, and I still remember his signature green jacket and his genuine interest in learning about me and my aspirations to maybe one day be a part of this organization. Over the next couple decades, we always connected at this meeting. He advised me on some historical projects, but best of all, he always checked in on how I was doing and what was going on with my family. And I'll always appreciate that about him. Here's a picture of the two of us at the Milwaukee Surgical Society in 2019 when Tracy Wang generously invited me to give a talk there. I'm just one of many in this room and beyond who have benefited from Stu Wilson's mentorship and friendship, and I'm so honored to be giving a talk named after him. He unfortunately could not make it to this year's meeting, but I was able to talk to him on the phone earlier this week, and he sends his best wishes to all of his friends here at AAES. Dr. Wilson is one of just 11 recipients of the Oliver Cope Meritorious Achievement Award. It's the highest honor that the AAES bestows, and that's a natural segue for me to transition to the subject of this historical lecture, the life, career, and impact of Dr. Oliver Cope, namesake of this honor. Oliver Cope was born on August 15, 1902, in Germantown, Pennsylvania, in the northern suburbs of Philadelphia. His family was part of a long-standing community of Pennsylvania Quakers, and Cope's upbringing was instilled with the fundamental Quaker values of simplicity, peace, integrity, community, equality, and stewardship, values that would profoundly impact his life and career. Cope's father, Walter, was an architect who unfortunately passed away shortly after Oliver's birth in 1902. Cope's mother, Eliza, was a pacifist and an outspoken activist for women's suffrage, and she raised Oliver and his 4 siblings with a strong emphasis on education, The family learned and spoke multiple languages in their home to the point that English was forbidden at the dinner table. Eliza also imparted a love of music to her children, and Oliver was a lifelong avid violinist. Unsurprisingly, he excelled in his studies, and in 1919, he enrolled at Haverford College, a Quaker institution not far from his childhood home. But he yearned for something more, and during his first year, he attended a concert in Philadelphia by the Harvard Glee Club, and he was so inspired by the artistry of this group and the intellectual opportunities offered to him at Harvard that he transferred there in his sophomore year, and he would remain at Harvard for the rest of his life and career. They call it a true preparation H when you go to Harvard for undergrad, med school, and residency. At Harvard, Cope majored in chemistry, sang in the Glee Club, but was also active in social issues. He helped to lead efforts to change Harvard's discriminatory admissions policies towards Jewish students. He then crossed the Charles River to Harvard Medical School in 1923. During med school, he took an extra year to explore some of his interests outside of medicine and to also use his skills in foreign languages. He traveled to China and worked as a newspaper correspondent, and he was one of the only Western journalists to be granted access for an interview with famed political and military leader Chiang Kai-shek. It was during medical school that Cope was first exposed to surgery, which offered him the most stimulating combination of clinical and scientific opportunities. And he was accepted at his residency position at Mass General in 1928. The MGH surgical service during this era was an exciting place to be an aspiring surgeon scientist. The chief of the MGH West service was famed thoracic surgeon Edward Churchill. Churchill was a tremendously impactful clinical surgeon who performed the first pericardiectomy for constrictive pericarditis in the US. He also promoted the practice of delayed closure for infected traumatic wounds, and he developed systems during World War II for mobile blood banking, treating injured soldiers on the front lines. Churchill played an important role in creating a new model for the modern surgeon scientist. He strongly believed in the integration of clinical and scientific pursuits in academic surgery, and his residents and faculty were all expected to conduct research in addition to their clinical practice. Oliver Cope excelled as an intern and junior resident, and he impressed Churchill so much that Churchill took him on as his personal administrative and academic assistant. In 1929, Cope's second year of residency, he and Churchill made the observation that patients with pulmonary edema exhibit a distinctive pattern of rapid shallow breathing, which they attributed to stimulation of the J receptors in the distended lung capillaries. They published their findings, and they were rewarded with an eponym which is still in place today, the Churchill-Cope reflex, describing tachypnea seen in patients with pulmonary edema. And think about that. It's very impressive for an R2 to have a medical eponym assigned to them, but Oliver Cope was just getting started. Edward Churchill was also ahead of his time in advocating for surgical specialization in an era when the model of true general surgery was the norm. He assigned each of his faculty members and residents to concentrate on one or two specific areas in their research and practice. Oliver Cope's two assigned areas of specialty during residency might appear strangely different to the modern surgeon: burns and parathyroid. These two seemingly disparate areas were linked by a couple commonalities. First of all, no one knew much about either of them at the time, so they were ripe for scientific inquiry. And second, understanding of both would require a detailed knowledge of physiology and chemistry. Cope's interest in burn patients was initiated during med school when he cared for multiple victims of the 1928 Beacon oil explosion in Everett, Massachusetts. He dedicated himself to studying burn physiology and treatment during residency, and then continued this work as a faculty member. He ended up performing a number of impactful research projects on burns throughout his career, including studies on fluid and electrolyte imbalances, optimal surface treatments and timing of skin grafts, and consequences of inhalation injury. He and the MGH burn team were presented with the ultimate scientific and clinical challenge in 1942, when a devastating fire at Boston's Coconut Grove nightclub claimed the lives of more than 500 people and sent scores of burn victims to MGH. The hospital's disaster preparedness and existing high level of understanding of burn physiology and treatment resulted in successful outcomes for the vast majority of the badly injured patients. And much of the credit for these successes was given to Oliver Cope and his impactful research and leadership. Incidentally, the Coconut Grove fire is how I first became aware of Oliver Cope, not through endocrine surgery. I wrote my medical school thesis on the MGH experience caring for the Coconut Grove victims. And while Cope had just passed away a few years prior, I was able to interview Drs. Francis Moore and Brad Cannon, two of Cope's MGH colleagues at the time, and they told me some wonderful stories about Oliver Cope's scientific contributions, as well as his deeply caring nature. Oliver Cope's other area of specialty is one that all of us in this room are deeply familiar with, the parathyroid glands. Cope was first exposed to the parathyroids in medical school, and his introduction came about rather fortuitously. During his first year, he was randomly selected to participate in an experimental physiology course, which came with a summer research fellowship. And he was assigned a PI for this fellowship named Joseph Charles Aub, who was a Harvard internist and researcher who was studying parathyroid physiology. Joseph Aub became not just a research mentor for young Oliver Cope, but also a family member. Less than a year after Cope joined his lab, Joseph Aub married Cope's older sister, Elizabeth. Aub was instrumental in recruiting and mentoring what would turn out to be a dream team of Harvard parathyroid researchers, fellow internists Walter Bauer and Fuller Albright. Cope had close personal ties with both Bauer and Albright. He and Albright were medical students together at Harvard, and just a few years later, Walter Bauer joined the Aub lab as a research resident, working at the same time as Cope. These close personal and familial relationships that Cope formed early in his medical education would prove fruitful in his scientific and surgical career. Cope continued his study of parathyroids as a resident at MGH. Fortune favored the well-prepared, and Cope was given the opportunity to care for and eventually operate on the most famous parathyroid patient in history, Charles Martel. Martel was a New England native, born in 1896 in Somerville, Massachusetts, just one town over from the Harvard undergraduate campus in Cambridge. He studied at the Mass Nautical School and served his country during World War I, patrolling the North Atlantic and the English coastline on the USS New York. After the war, he joined the Merchant Marines and traveled the world, attaining the rank of captain. Captain Martel was a robust seafarer in his youth, 6'1", strapping and energetic, as shown here. But very early in his career, he started developing chronic back pain, which he attributed to the hard work that his job required. Things got worse, however. The pain spread to bones throughout the rest of his body, and he noted that his urine became milky. He lost several inches in height, and his chest wall expanded, what his clinicians would later describe as pigeon-breasted. And his appearance changed so much that his fellow sailors cruelly made fun of him. And then he started breaking bones, first his patella, then his forearms, to the point that in 1923, he was forced to retire from the Merchant Marines. X-rays of his skeleton showed widespread osteomalacia, and for the next few years, Martel resided at the U.S. Marine Hospital in Staten Island. And there, his doctors pumped him full of calcium and a host of other supplements intended to rebuild his bones, including cod liver oil, phosphorus, and thyroid extract. They also placed him in prolonged traction to try and stretch out his compressed spinal vertebrae. Unsurprisingly, none of this worked, and Martel was eventually transferred over to the metabolic unit at Manhattan's famed Bellevue Hospital, under the care of prominent physician and researcher Eugene Dubois. Dubois subjected Captain Martel to a battery of tests and correctly ascertained that Martel was suffering from a disorder of the parathyroid glands. And Dubois knew just the right person and place for Martel to go for further evaluation and treatment. One of his former residents was Joseph Aub at MGH, and Dubois had closely followed Aub's research in parathyroid physiology. So in 1926, he transferred Charles Martel up to Boston. 1926 was a paradigm-shifting time in the history of parathyroid surgery, just 1 century ago from us right now. In Vienna, Dr. Felix Mandel, in 1925, had performed what is widely attributed as the first recorded parathyroidectomy in another patient from the transportation industry, streetcar driver Albert Jahn. Dissemination of new knowledge was glacial in those days, however, and when Charles Martel was transferred to the MGH, the parathyroid team there was unaware of what had transpired across the Atlantic. Joseph Aub analyzed Martel's biochemical profile and confirmed what Eugene Dubois had first postulated. Martel had primary hyperfunction of the parathyroid glands caused by a parathyroid tumor. He needed parathyroid surgery. There was no such thing as an endocrine surgeon at the time. And remember, Oliver Cope was actually still just a med student in 1926. So the operative task fell to Chief of Surgery Edward P. Richardson. Richardson came from a prominent family of MGH physicians. His father was famed abdominal surgeon Maurice Richardson, who invented the Richardson retractor. Edward Richardson had experience with thyroidectomy, but little knowledge of the parathyroid glands. No surgeon did at that time, and Richardson himself freely admitted this, so on the day of Martel's first operation, he demanded that the internist and parathyroid physiology expert Fuller Albright be at his side during the case. In Richardson's words, quote, "I want you to be right at my elbow to show me a parathyroid, as I don't know what they look like." You imagine him asking your endocrinologist to come in your OR now, right? Richardson ended up performing 2 separate neck explorations on Martel in 1926. Final pathology showed that he removed 2 normal parathyroid glands, along with a lot of cervical fat. Martel's calcium remained elevated, and over the next few years, he suffered worsening skeletal ravages of his hyperpara. He returned to New York to work as an insurance broker for the Merchant Marines, and in 1932, he underwent yet another failed exploration, this time by Dr. Russell Patterson of Cornell. Martel continued to decline precipitously, and later in 1932, he returned to MGH, where he would spend the rest of his too short life. He had lost a full foot in height, and he was in constant debilitating bone pain that left him bedbound and unable to walk. Unlike his first admission to MGH, however, this time, Martel had a surgeon who had rigorously studied the parathyroids in anatomy and physiology, Dr. Oliver Cope. Cope had spent the past several years immersed in parathyroid research, which, as I mentioned, had started with his very first lab experiences as a med student. In 1931, when Cope was a senior resident, his boss and mentor, Edward Churchill, assigned him to learn everything he could about parathyroid anatomy. Churchill was motivated by the failed experiences with Captain Martel, as well as some other patients at MGH, and he knew that surgeons could do better. As Cope would later put it, quote, "Churchill discerned that the success of parathyroid surgery must lie in the ability of the surgeon to know a parathyroid gland when he saw it, to know the distribution of the glands, where they hide, and also to be delicate enough in technique to be able to make use of this knowledge." Oliver Cope, whom I should again emphasize was a senior resident at the time, headed to the pathology suite, where he joined forces with his friend, pathology resident Benjamin Castleman. Together, they performed post-mortem examinations of more than 30 cadavers, and they started from a point of relative ignorance. In Cope's words, "At first, we were all uncertain about the identity of the little pieces of fat." Cope would painstakingly dissect out the neck, find what he thought might be a parathyroid, and turn it over to Castleman for microscopic analysis. With more reps came an eventual level of expertise, and that's where I got the title for this talk. The more we looked, the more glands we found, and the wider we found them distributed. They were to be found over their entire theoretic embryologic distribution, from high up in the neck, well above the thyroid upper pole, down into the anterior mediastinum, along with the thymus. After more than 6 months in the pathology suite, Cope had developed an eye for the parathyroid glands and a nuanced understanding of their possible locations. So Edward Churchill felt that Cope was ready to embark on his first actual parathyroidectomy, and this took place at the beginning of 1932. Chief Resident Cope learned quickly, however, that simple knowledge of parathyroid anatomy and appearance was not enough. One had to be delicate and patient. Even though the case resulted in the successful resection of an adenoma, Churchill debriefed with Cope and advised him that he had been too rough with the tissues, resulting in a bloody field and unnecessary struggle. And he requested that Cope use pledgeted traction sutures to retract the thyroid instead of sharp hooks. And he also said he should switch dissecting scissors from the big pair that Cope had been using in his cadaver studies to a smaller, more refined scissors that allowed him to operate more precisely. Like many residents about to finish training and start practice, Cope was not happy with Churchill's critical feedback, but he eventually understood that Churchill was right. Cope adapted his technique and instruments accordingly. But that wasn't the hardest part. In Cope's words, quote, "What I found most difficult was to slow my pace and move carefully." Cope exhibited an admirable level of self-awareness in admitting that he needed to counteract some of his deep-seated personality traits in order to become a successful parathyroid surgeon. "When my temperament makes me impatient, I have to restrain myself. When my restlessness leads me to move too quickly, I pay for it." Wise words that still ring true for any parathyroid surgeon today. Edward Churchill scrubbed for Cope's second parathyroidectomy, and then he stepped back, peering over Cope's shoulder during his third case, and then leaving him to operate independently after that. Cope finished his residency and immediately joined the MGH faculty. One of his first patients in practice was none other than Captain Charles Martel. Now, for all of the fellows about to start practice, be thankful that your first cases are hopefully unlikely to include a multi-redo non-localized para in a severely debilitated patient. Cope ultimately performed 3 unsuccessful parathyroid explorations of Martel's neck. At this point, Captain Martel took matters into his own hands. In an amazing example of patient-directed surgical care, Martel informed his surgeons that they needed to look where they had not looked before, in his chest. And how did he know this? During his lengthy stay at MGH, he had done extensive readings of textbooks and journals on his own disease process, and he learned that ectopic parathyroid glands could migrate all the way down into the mediastinum. Cope himself had encountered this during his cadaver dissections. And fortunately for Cope and Martel, there was an expert thoracic surgeon available, Edward Churchill. On November 2nd, 1932, Edward Churchill performed Martel's 7th and final parathyroid operation, a sternotomy and mediastinal exploration, identifying the culprit 2.5 centimeter parathyroid adenoma adjacent to the superior vena cava. After multiple operations with resection of normal glands, compounded by profound bone hunger from his osteoporosis-ravaged skeleton, Charles Martel, not surprisingly, developed severe hypocalcemia and tetany. 6 weeks after finally undergoing successful parathyroidectomy, Charles Martel passed away from laryngospasm following an operation to remove a ureteral stone. He was 36 years old, and by many accounts, he remained positive, hopeful, and determined to beat his terrible disease until the very end. And his story certainly lives on, told and retold by endocrine surgeons worldwide. Oliver Cope joined the MGH faculty in 1932, and MGH remained his only professional home for the next 6+ decades. 1932 was a banner year for Cope for a different, more important reason. He married Alice de Normandy. Alice hailed from a prominent Boston family, and she shared many of Oliver's values, especially a dedication to helping the less fortunate. Alice Cope would later co-found and help run the Window Shop, a store and bakery in Cambridge that provided employment and services for refugees from the European conflicts. It was also one of the first and only businesses in the area to employ Black women. Soon after starting as an attending, Oliver Cope received a prestigious Moseley Traveling Fellowship to explore and learn in Europe. But this was a tumultuous time on the European continent, and the Copes had to rapidly pivot from their original itinerary. They started in Germany, but immediately came face to face with the newly installed Nazi Party, whose ideals and actions ran counter to Cope's Quaker values. Cope was particularly appalled by the mistreatment and persecution of Jewish physicians and scholars. He and Alice left Germany quickly and headed to London, where he befriended and learned from surgeons at University College Hospital and engaged in physiology experiments at the National Institute of Medical Research. Just a few years later, the Copes would repay the hospitality and graciousness bestowed upon them in England when they hosted Cope's friend, Dr. Harold Himsworth, and his entire family after they were displaced by the London bombings. Upon his return to Boston in 1934 after the Moseley Fellowship, Oliver Cope dove right back into his research and practice in parathyroid surgery. Over the subsequent decades, he and his colleagues expanded the understanding of parathyroid physiology, anatomy, and pathology, and Cope himself performed many more parathyroid operations, and he taught the world about the best ways to find and remove diseased parathyroids. Our modern-day conceptions of the metabolic consequences of primary hyperparathyroidism, the stones, bones, and groans that every medical student learns, were largely the products of clinical observations from the team at MGH, internist Joseph Aub, Fuller Albright, Walter Bauer, and the pathologist Benjamin Castman, all close collaborators and friends of Oliver Cope's. They reported on the association of primary hyperparathyroidism and peptic ulcer disease, laying the foundations for later work by investigators such as Stu Wilson, namesake of this lecture, who helped elucidate the clinical manifestations of MEN1. They were also the first to describe acute pancreatitis as an unfortunate metabolic outcome of severe hypercalcemia from hyperparathyroidism. As biochemical testing for calcium, phosphorus, and PTH became more refined and accurate, and awareness of parathyroid disease increased, earlier diagnosis of primary hyperparathyroidism became possible. The MGH group was one of the first to highlight the spectrum of neurocognitive signs and symptoms that could result from untreated hyperparathyroidism: fatigue, weakness, depression, personality changes, and, as Cope worded it, mental fuzziness, all of which could improve with successful parathyroidectomy. Cope was also the first to publish on four-gland hyperplasia, identifying it as a different clinical entity from the much more commonly seen single adenomas. Publishing was a key component of Cope and his MGH colleagues' legacy in transforming parathyroid research and practice. Starting in the 30s, Cope continuously produced papers on his experiences and outcomes with parathyroidectomy. He updated his case series in the 40s, 50s, and 60s, culminating in two landmark papers: 1961's The Vicissitudes of Parathyroid Surgery, presented at the American Surgical Association and published in Annals of Surgery, and referenced by the great James Lee during his distinguished professor talk yesterday. And 1966's The Story of Hyperparathyroidism at the Massachusetts General Hospital, published in the New England Journal of Medicine. The word vicissitudes is defined as the unpredictable ups and downs, changes, or fluctuations in fortune and circumstances that everyone experiences, an elegant way to talk about parathyroid surgery. This paper is a remarkable example of surgical honesty and humility. By 1961, Cope had performed nearly 300 parathyroid operations, probably more than anyone in the world. But this paper was not about his successes, but rather the 51 cases in which he had failed in some way. Cope was unflinching in sharing with the world both his triumphs as well as his mistakes. The 51 case reports included descriptions of incorrect or delayed diagnoses, as well as surgical complications, failed explorations, postoperative tetany, even deaths, essentially everything he had learned during his career as a parathyroid scientist and surgeon. In the final section of this vicissitudes paper, he reflected on his experiences. Quote, "No excuse or apology is offered. Nothing ventured, nothing gained, and there has been some gain." He went on to emphasize one of the most important lessons he had learned: making the correct biochemical diagnosis. That's Kwandu rule number 1. He preached patience rather than rushing to the OR. Quote, "Determinations need to be repeated, sometimes over long periods. Hyperparathyroidism, like many other endocrine conditions, fluctuates in intensity, and often it can be ruled in or out by watching." Circling back to his days in the pathology suite, Cope underscored the foundational importance of really knowing parathyroid anatomy. 3/4 of them are reasonably situated in readily accessible places. 1/4 are off somewhere out of the way in a wide domain and often hard to find. This difficulty is inherent to the patient in his embryologic development. It is not our fault, but it can sometimes defeat us. Cope was not a one-trick endocrine surgeon, only concentrating on the parathyroids. He also researched and treated a wide range of thyroid disorders, including impactful studies on hyperthyroidism and non-toxic goiters. He was among the first to describe the entity of hot nodules identified on thyroid uptake scanning. In total, he published 20 papers on thyroid diseases and surgery. He also had an interest in the adrenals. Decades before CT scans, Cope used a technique for visualizing adrenal tumors with X-rays by injecting air into the retroperitoneal space surrounding the kidney. In 1955, he published on 46 patients with Cushing's who were successfully treated with adrenalectomy, one of the first such series in the literature. Oliver Cope did not limit his practice to only endocrine surgery. In fact, the area in which he had his most profound and lasting impact was the treatment of women with breast cancer. For nearly a century, the standard of care for breast cancer treatment was radical mastectomy, championed by William Halsted and others beginning in the late 1800s. This operation was aimed to eradicate every last possible cancer cell and was therefore incredibly morbid and disfiguring. Oliver Cope had been trained during the heyday of maximally invasive surgery, but after doing radical mastectomy for a couple decades in practice, he began questioning the existing dogma that this disfiguring operation was the best one-size-fits-all treatment for breast cancer. The development of targeted radiation therapy in the 1940s and 50s introduced an alternative adjunct modality that could be combined with surgery and allow for less aggressive surgical treatment. Beginning in the 50s and 60s, Cope advocated for limited breast resection with adjunct radiation as a treatment strategy for women with breast cancer. Not surprisingly, he was roundly criticized and even denounced by his surgical colleagues at MGH and beyond, who could not imagine pulling back from the entrenched standard of care, radical mastectomy. Cope, never one to back down from his beliefs and convictions, decided to fight the establishment. He wrote numerous impassioned editorials, such as this one pictured here, and he did not mince words, as evidenced by his title, where he referred to radical mastectomy as mutilating. He also took the fight public, spreading his message beyond a purely medical audience by publishing articles in magazines like Vogue and the Ladies' Home Journal, advocating for women with breast cancer to really question their surgeons about their treatment options. He then took things one step further. In 1977, he published a book entitled The Breast: Its Problems, Benign and Malignant, and How to Deal with Them. This book was intended for a lay audience of women with breast disease, and it became a bestseller, going through 2 editions. Oliver Cope was ultimately proven correct in his convictions when the results of the NSABP trial and other studies demonstrated the efficacy of breast-conserving surgery with adjunct radiation therapy compared with traditional radical mastectomy, and it paved the way for current paradigms in breast cancer care. After making lasting impacts in the diverse areas of endocrine surgery, treatment of burns, and breast cancer, Oliver Cope dedicated the later decades of his life and career to 2 interrelated causes: the mind-body connection and medical education reform. Cope had always been a deeply caring and compassionate person and physician. During his career, he witnessed remarkable advancements in medicine and science, but he also observed what he believed to be a corresponding decline in the emotional connections between doctors and patients. He felt that doctors had become too cynical and uncaring. Despite being an accomplished scientist himself, Cope blamed the increasing prominence of science in medicine for the decline of physician empathy. He believed that science had made doctors cold and dispassionate, indifferent to the emotional needs of their patients. And as a result of these observations, Cope became obsessed with the mind-body connection and its influence on human health. He urged his fellow physicians and researchers to more deeply study the effects of patients' emotional and mental states on their bodies and what somatic diseases might result. This led him down some paths that ultimately proved quite incorrect, such as his longstanding belief that Graves' disease was caused by psychological and emotional stress. Cope came to the conclusion that medicine needed to make a sharp pivot towards research in the behavioral sciences, such as psychiatry and psychology, and that better understanding of the mind-body connection would both increase empathy and compassionate care of patients and also allow physicians to more effectively treat a wide range of disease processes. And he felt strongly enough about this subject that he published a book, 1968's Man, Mind, and Medicine, which was sent to every medical school in the US with enough copies that every medical student could have one. The accompanying press tour emphasized the fact that this crusade to better understand the human mind and to improve physician empathy was being led by a surgeon. There was one Florida newspaper which ran a feature on Cope with a headline, "A surgeon treats the patient as a person." From the Medical Tribune, quote, "For a surgeon like Dr. Cope to be deeply, passionately, genuinely concerned about the feelings of patients actually comes as a shock." Cope also strongly believed that change in medicine needed to start at its very foundations, in medical schools, where the next generation of physicians was being shaped. Again, Cope felt that the heavy emphasis on the biomedical sciences during med school discouraged the development of medical students' sense of empathy and compassion. In his words, quote, "Something happens during their 4 years. The educational mold distorts their vision in such a way that they become increasingly centered on the sciences to the detriment of their interest in the behavioral and emotional aspects of the patient. Cope advocated for a complete revamping of existing medical school curricula, centering the doctor-patient relationship and the mind-body connection, with greater attention and time paid to the psychosocial aspects of medicine. While many of his colleagues, especially those in surgery, thought that Oliver Cope had once again gone off the deep end with his idiosyncratic, iconoclastic beliefs, slowly but surely, at least some of his messages got through. In 1985, when Oliver Cope was in his 80s, Harvard Medical School introduced its revamped medical school curriculum called the New Pathway, which contained several elements that Cope had championed over the years: a broader view of medical education beyond the core biomedical sciences, and an incorporation of teaching modules aimed at promoting and nurturing a sense of empathy, compassion, and dedication to caring for the patient as a whole human being and not just a disease or a body part. A few decades before the New Pathway, Oliver Cope had already helped to promote meaningful change at Harvard Med School. In 1943, Cope was one of 6 members of a committee formed to help determine whether women would be admitted to HMS. Discussions and debate amongst the overwhelmingly male faculty ran hot. I don't have records of Cope's specific comments during these meetings, but one can extrapolate from Cope's personal history. He was raised by a suffragette mother who instilled Quaker values, one of the most important of which is equality. He already had a history of promoting social justice when he protested for fair admissions processes for Jewish students at Harvard. Cope almost certainly spoke his mind in favor of admitting women to HMS. There was definitely resistance, including one professor of gynecology who stated in a letter to the dean that, quote, "The primary function of woman is to bear and raise children, and the first social duty of woman is to develop and perpetuate the home." In the end, it wasn't even close. The faculty voted 56-3 in favor of admitting women, and in the fall of 1945, the 12 women shown here entered the first-year class of Harvard Medical School. Alice and Oliver Cope were the parents of 2 children, Eliza and Robert. They frequently hosted students, residents, faculty, and friends at their homes in Cambridge and Rhode Island. Oliver maintained his love of music for his entire life, and he often entertained guests on the violin. He became professor emeritus in 1969, but remained quite active on a number of fronts, including his advocacy for breast-conserving surgery, medical education reform, and the mind-body connection, as I detailed early. He passed away on April 30th, 1994, just one day after his beloved wife, Alice, and they had been married for 62 years. And he lived long enough to see many of the causes that he championed bear fruit. The NSABP trial promoting lumpectomy instead of radical mastectomy, the New Pathway, and most important to everyone in this room, the rise of endocrine surgery. Cope operated on Captain Charles Martel, the first person to ever undergo parathyroidectomy in the United States. And decades later, he witnessed the birth of a surgical society dedicated to elevating the science and practice of the new specialty he helped create, endocrine surgery. And the AAES held its first meeting in 1980. In 1984, the leadership of our organization created a Special Achievement Award intended to celebrate only the most remarkable of surgeons for their unsurpassed excellence in teaching, research, and practice. The first recipient, and the person for whom this award will be named in perpetuity, was Oliver Cope. He received his namesake award in Toronto in 1985. Since then, 10 other surgeons have received this highest of honors from the AAES. There's an epilogue to the story of Oliver Cope and the AAES that connects him to the namesake of this lecture, Dr. Stuart Wilson. I must give credit to Saray for digging this up from the Cope archives. In 1988, Stu Wilson was the secretary of this organization, then as now both the most important and thankless of officerships. Hi, Carrie. Hi. This meant he was tasked with informing Oliver Cope that his abstract had been rejected. Just 3 short years before, Cope had been awarded the highest honor of this organization, an award that was named for him, and Stu Wilson had to tell him, no thanks. Now, you take a look at the title and subject, and it all becomes a little clearer. The concept that Graves' disease is a psychosomatic disorder. Evidently, that year's program committee was not buying it. So for all of you out there that have ever had your abstract rejected, take heart. Even the most decorated of endocrine surgeons has felt the same. I'd like to close by following the example of one of our select few Oliver Cope Award recipients, Dr. Janice Pasieka. In her memorable 2010 presidential address of the AES in Pittsburgh, Dr. Pasieka asked us all to follow the example of legendary physician and clinician Sir William Osler in the way we take care of patients, perform research, and live our lives. And she coined her own catchphrase, which I think many of us still think about to this day: dare to be Oslerian. Today, I ask you all to take similar inspiration from the life and career of Oliver Cope. Now, I could not conjure up anything nearly as catchy as Janice's dare to be Oslerian. The best I could come up with was hope to be Cope. But there are many lessons we can all take from Oliver Cope's example. Number one, ask and answer questions. Cope was unfailingly curious about the world around him, even as a young medical student and resident, and he sought answers to his questions through rigorous scientific investigation. Spurred on by his mentor, Edward Churchill, he studied parathyroid anatomy in cadavers in painstaking detail before he ever embarked on an actual parathyroid operation. Over several decades, he analyzed the results of his experience with parathyroidectomy and unflinchingly reported on what he had learned, mistakes and all. His inquiry was not limited to technical operations, but aimed at understanding the broader, fundamental biochemistry, physiology, and pathophysiology of the parathyroid glands. Number two, challenge existing dogma. Oliver Cope's career was marked by his continual quest to change existing paradigms, or in some cases, to banish them completely. He repeatedly tilted at the windmills of the medical establishment, from promoting novel treatment protocols for burns, to advocating for less invasive therapeutic strategies for breast cancer, to challenging the very foundations of how to best teach medical students, as well as helping to reshape the idea of who was even allowed to enter medical school at all. This segues into the next of Cope's principles: fight for what you believe in. Cope's deep-seated sense of justice and purpose led him to speak out and fight unabashedly for what he thought was right. This could be to the detriment of his professional and public image. He absorbed considerable criticisms throughout his career for his iconoclastic beliefs, but he never shied away from speaking his mind and striving for change. It took years, or in some cases decades, but Cope was ultimately proven correct in many, although not all, of his crusades. And last, be kind. Professionally and personally, Oliver Cope embodied the Quaker values of his upbringing, especially in his dedication to caring for those less fortunate and speaking out on behalf of those who are not heard. His contributions to surgical science and practice, hyperparathyroidism, burns, breast cancer, and beyond, improved the lives of countless patients, and his advocacy for the causes he believed in may have had an even more profound impact. So the next time the Cope Award is given, or the next time you struggle to find an elusive parathyroid, or the next time you feel compelled to challenge existing dogma or speak out on what you believe in, take a moment to think of Oliver Cope and the example he set for us all. Thank you very much for this honor.
Thank you, Dr. Shen. I knew you would do an amazing job, even when you were moving from San Francisco to New York, and these were difficult times.
I actually have to tell a story. I actually turned her down. I said, I don't want to do this, right?
Several times, several times.
So she circled back 2 months later and said, you're doing it. And so
Well, he
yes.
suggested several other people, which I interviewed and came back to him. He tried his best. Thank you very much.